So we're talking about secondary IOL implantation without capture. We're talking about the why and when and where and how. And we revert to secondary IOL implantation. We have an aphakic patient to correct their aphakia, obviously, and avoid amblyopia. These patients have undergone lensectomy or irrigation aspiration, but at the time of irrigation aspiration, we could not implant for one reason or the other, whether it was trauma and we were afraid of a retained intraocular foreign body inflammation or infection, or we were not so sure about our capsular support. So basically, when do we implant in the sulcus? When we are sure about our capsular support. It's not necessarily 360 degrees, but as long as you have good support 180 degrees apart, it's quite good. And we have to have a patent sulcus, meaning that we don't have posterior synechia or lens matter that is retained that will cause any decentration of your IOL when you implant it. We implant the IOL in the sulcus, that's to say, between the posterior surface of the iris and the capsular complex, whether it be the anterior capsule alone or the anterior and posterior capsule, regardless the condition of the posterior capsule. And what are we going to implant? We're going to implant a foldable, 3-piece, acrylic, hydrophobic IOL. Whether it is whichever the brand is, but we need an IOL that has a large overall diameter, 13 millimeters, and optic that is big, 6 millimeters, and a posterior angulation to keep the optic away from the iris so it wouldn't be rubbing against it. The technique here is shown in detail, and the case is a resident case. Sorry, just a second. Here she starts by opening her side ports first and reforms the anterior chamber with viscoelastic and makes sure that her sulcus is patent. She is injecting right now viscoelastic in the sulcus, and then she will introduce her iris suppositor to cut a posterior synechia at around 7 o'clock in the video in front of you. And there she goes in the sulcus to make sure that there aren't other hidden adhesions between the iris and the capsule. There you go, it snaps. Yes. And then she will open her main incision. She finds the globe a little bit soft, reforms, and then opens the incision with the keratome. She will widen the incision a little bit as the keratome is small, smaller than 3 millimeters, and you will need to widen it so you can introduce the plunger, the cartridge. Here, loading the IOL, and it's very important that you load the IOL by yourself and following all the recommendations of the manufacturer. And then, as she introduces the IOL, she will introduce her leading haptic directly into the sulcus. And as the IOL goes into the sulcus, yes, the haptic going into the sulcus, the optic is being delivered, and then she will simply dial this IOL into with the trailing haptic into the sulcus, and you have a nicely round pupil. At the end, remember to close your incisions, because especially when the children are young, you will have to close all your incisions. The next case is a professor case, which basically uses the same technique. However, the main incision is opened early on. The sulcus, as you see, the capsule is present, as we see, actually all around. You find it up at 12th position. And again, the IOL is directly injected into the sulcus. However, and yes, there it goes in. Perfect. Here we have a different situation where we had posterior synechia, and after the assistant lecturer released them, the pupil went down. So what he had to do, he injected the IOL in the anterior chamber, and then using a push-pull, he grabbed the the haptic and released it into the sulcus, allowing it to spring in, dialed the IOL, and did actually the same with the trailing haptic. So basically, this procedure is simple, however, it's not free of complications. One haptic can be in the sulcus, the other in the bag, leading to tilting, or even in the vitreous, leading to falling of the IOL. Correctopia can occur, and inversely implanted IOL can cause pupillary block and glaucoma. However, we agree that if you have all the prerequisites, it is a short procedure, doesn't lead a high learning curve, and relatively it is of low complication rate, and it is independent of the posterior capsule condition, whether it's opened or not, whether the capsule is opened with a large opening, 6 millimeters for example, or not. And when you want to take it out, it will be easier. So the take-home message is, if you have enough capsular support and the patent sulcus, go ahead implanting the sulcus easily. If not, then wait for the next presentations, because you have so many options. Thank you very much.